Bueno, vamos a comenzar esta actividad del Ateneo del HPR. Quiero agradecer al Comité de Docencia e Investigación por la oportunidad de llevar a cabo esta actividad, igual que al Laboratorio Pfizer por darnos un aporte al Comité de Docencia e Investigación en este tipo de actividades. Esta es la segunda actividad que hacemos de simposio de amiloidosis. La primera fue con el doctor James Moons y Mace Hanna. Today we have the opportunity to have Marianna Fontana. As a brief introduction, Marianna is the director of the USL CMR unit at the Royal Free Hospital. She is professor of cardiology and honorary consultant cardiology at the National Amiloidosis Center, at the University College of London, where she is deputy head of the center and deputy clinical lead. She obtained her medical degree and qualification as a cardiologist at the University of Pisa in Italy. She was appointed deputy head of the Center of the Amyloidosis and Acute Phase Protein and deputy clinical lead of the National Amyloidosis Center in 2019. She was awarded with an intermediate fellowship from the British Heart Foundation in 2018, and her research interests include CMRI with multiparametric mapping and pathogenesis, diagnosis, and treatment of cardiac amyloidosis. Much of what we know about this disease comes from research work by her and her group in the UK. So Marianna, we are very excited to have you here. She's going to give a 30-40 minutes lecture about a diagnostic kit of a growing disease. I will co-chair this activity with my partner, Juan Bonelli. He's the chief of the Cardiovascular Imaging Department and the Gamma Institute and Private Hospital of Rosario. And after that, we are going to have a 20-minute Q&A with a very distinguished local expert panel. We have Eduardo Perna. Eduardo is the president of the Argentine Federation of Cardiology. We have Diego Pérez de Arenaza. Diego is the chief of the Cardiovascular Imaging Department at the Italian Hospital in Buenos Aires. And Jorge Camilletti. Jorge is the past president of the Argentine Federation of Cardiology, and he's the chief of the Cardiovascular Department at the Italian Hospital in La Plata. So welcome everybody. Marianna, we will continue with your lecture.
Thank you very much for the introduction. It's a pleasure for me to be presenting this talk today. I will focus on the cardiac amyloidosis diagnostic case of a chronic disease. So, I will briefly speak about the presentation, what we use imaging, but also non-imaging wise to make a diagnosis. And then I will focus also on a bit of treatment, so why typing the disease is so relevant and why an early diagnosis is so relevant nowadays. This is my disclosure. So what is amyloid? It's an abnormal extracellular fibrillary protein that deposits into the different organ and tissues. The way we identify amyloid is by the pathognomonic green body fringes after color red staining. There are more than 30 different proteins which form amyloid in vivo, and deposits and form amyloid. So amyloidosis, as opposed to amyloid, is the disease caused by the amyloid deposits, which can be localized or systemic. Systemic amyloidosis is usually a fatal condition and causes about 1 per 2,000 deaths in the UK. Diagnosis and treatment are difficult, but major recent advances have been made, especially on the diagnostic front, with better outcomes. But still, there is a major unmet clinical need as regards awareness, early diagnosis, and start early treatment. So whilst there are more than 30 proteins that can form amyloid in vivo, there are two main types of cardiac amyloidosis, AL and ATTR amyloidosis. So AL is a monoclonal light chain in the bone marrow that is able to produce light chain that then misfolds and deposits into the different organ and tissues. This can just be a plasma cell dyscrasia, which is usually subtle. So usually we don't have over-myeloma, but in some cases we have. And the yellow amyloidosis is often diagnosed very late for very wide variability on the phenotypic presentations. The other common type, which probably nowadays is felt to be more common than AL, is transthyretin amyloidosis. Transthyretin amyloidosis, we have two types. So in transthyretin amyloidosis, what happens is that there's a protein called transthyretin, which is normally produced by the liver, but then this protein misfolds and deposits into different organs and tissues. So we have two types of ATTR amyloidosis. One where the gene is wild type, and so we call it wild type ATTR amyloidosis. And this is predominantly a cardiac phenotype. And then the second type is hereditary ATTR amyloidosis, where the TTR gene presents a variant. And in this, the phenotype can be variable, as I will explain in detail later. So in systemic AL amyloidosis was felt to be the commonest diagnosed form of cardiac amyloidosis, although this is rapidly changing and probably ATTR is now the most common one. Cardiac involvement in systemic amyloidosis is present in 50 to 90% of the cases. And the amyloid forms from the light chain produced by a subtle or over plasma cell dyscrasia in the bone marrow. The prognosis is extremely poor because if cardiac amyloidosis is left untreated, the prognosis is less than 6 months. And the median age of diagnosis is 50 to 60 and may coexist with multiple myeloma, but only in 15% of the cases. ATTR amyloidosis instead, as briefly mentioned, can be acquired, so wild-type ATTR amyloidosis or hereditary. In wild-type ATTR amyloidosis, the phenotypic presentation is of a cardiomyopathy with a restrictive phenotype. Is increasingly recognized cause of heart failure, especially in men. There's a striking male predominance, like 94% of the patients are men. And typically the patient present with shortness of breath. Autopsy studies indicate that we can find amyloid deposits in up to 25% of the patients over 85 years old of age. But again, it's very important to distinguish amyloid deposits from cardiac amyloidosis, which is the clinical syndrome associated with the deposits. What we need to bear in mind that the vast majority of cases of cardiac amyloidosis are not diagnosed in life, so we really need to make an effort to try to identify those cases. So hATTR amyloidosis, so the form of ATTR amyloidosis where there's a mutation in the TTR gene can present with a cardiomyopathy phenotype or with a neuropathic phenotype. But most commonly, the phenotype is a mixed phenotype between the two. So there are more than 120 TTR mutations that can result in hATTR amyloidosis. And we can do a possible genotypic-phenotypic association in hATTR amyloidosis. But we also need to bear in mind that in each specific patient it's important to do an individualized assessment because some of the mutations, for example, were commonly considered only cardiac, like V122I. We now know that in a good proportion of patients we can find also neurological phenotype. And you will see that identifying the phenotype in hATTR amyloidosis is extremely important because it opens new and different therapeutic strategies. And we also need to bear in mind that there are differences between the different mutations, but also differences within the same mutation in the phenotypic presentation, but also difference within the same family with the same mutation. So really an individualized assessment is absolutely essential. What's important to bear in mind is that widespread peripheral neuropathy has a huge impact on the patient quality of life. What determines prognosis is actually the cardiac involvement. In patients with cardiac involvement, the survival is between 2.5 and 4 years. So how do typically present these patients? In TTR amyloidosis, history of bilateral carpal tunnel syndrome is extremely common, usually 5 to 10 years before presentation. Patients often present or go on presenting advanced degree of AV block, so pacemaker implantation is common. They can have peripheral neuropathy and autonomic dysfunction. One can be predominant or there can be a combination of the two. So Typically, when we talk about peripheral neuropathy, this is an axonal-dependent, length-dependent peripheral neuropathy. So the numbness and pins and needles starts from the feet, and they then become more evident going proximally. So starts from the feet, and then from the hands, and then progresses proximally. Autonomic dysfunction, typically erectile dysfunction, diarrhea, alternative constipation, but also vitreous opacity can be found in some of the patients. In AL amyloidosis, the presentation can be extremely variable because in AL amyloidosis, every organ can be affected. So a patient can present with nephrotic syndrome, they can present with peripheral neuropathy, autonomic dysfunction, they can present with predominant cardiac involvement or predominant soft tissue with a typical macroglossia, easy bruising, so what is described as standard eyes. And also gross kind of soft tissue involvement with also extensive lymph node involvement. Typically, patients with both AL and TTR, but most severely AL patients, will be extremely intolerant to standard heart failure medications. So then what can we do to diagnose these patients? So ECG is a test that we do in all the cardiac patients, and traditionally what we have been taught during medical school that in amyloidosis we found low voltages in the limb leads, and this contrasts with the increase in LV mass on the echo. While this is definitely true in a proportion of patients, we now know that there's a huge variability on the type of ECG that we can have in this patient. So for example, if we see LVH criteria, we shouldn't exclude cardiac amyloidosis because actually presence of LVH criteria on the ECG is relatively common in patients with ATTR amyloidosis, although less common in AL. Again, atrial fibrillation extremely common and first degree AV block, but also more advanced, more severe degree of AV blocks are extremely common. So this is really a huge ECG diversity. But what about cardiac imaging? The first imaging modality that we all use in every patient that presents with heart failure is echocardiography. So patients, they do present with concentric hypertrophy. Again, this is different from the kind of old kind of notion that usually the hypertrophy is symmetric in amyloidosis. There is commonly atrial dilatation. The ejection fraction is preserved, but actually the longitudinal function is severely impaired in these patients. Severe diastolic dysfunction is common, but in some of the patients we can also find very early diastolic impairment. Pleural and pericardial effusion are common, but most prevalent in AL rather than ATTR. Strain imaging definitely can make the assessment more accurate, but also more specific. So what we do with longitudinal strain is that we assess the extent and timing of the myocardial deformation, and is expressed as the peak mean negative strain for each of the myocardial segments. And what typically happens in patients with cardiac amyloidosis is that there is a reduction in the longitudinal strain in the basal and mid segment. We preserve longitudinal strain in the apical segments, and this gives the typical bullseye appearance of when we display the longitudinal strain in the polar plot map. You see here on the lower right corner that there is preserved longitudinal velocity in the apical segment, here the red, but reduce longitudinal strain in the basal and mid segment. And again, this is the typical appearance that we see in these patients. The problem with echocardiography is that whilst we can stratify the probability of presence or absence of cardiac involvement, and there are a few papers recently published that suggest that a multiparametric score mapping is really useful to stratify the probability, but it's extremely difficult to say just based on the echo. If we have 4 patients with increase in LV mass, definitely point the finger and say, oh, this is definitely the patients with cardiac amyloidosis. And the real problem is because we don't have any information about the tissue composition. So we don't have any information about the underlying process which actually drives the disease, the clinical phenotype and the disease progression. So what we all have been taught is that the gold standard for cardiac amyloidosis is the biopsy. So how do we get information of the tissue composition via a cardiac biopsy? However, biopsy and staining of affected organ doing a biopsy is quite common, especially cardiac. In the UK, for example, renal biopsy is quite commonly done. As soon as a nephrologist sees a nephrotic range proteinuria, then a renal biopsy is performed. And in fact, actually, renal physicians are very good at picking up systemic amyloidosis for exactly this reason. However, at least in the UK, cardiac biopsy is very rarely performed, involves risk, introduces delay, and is quite expensive. And usually, cardiac biopsy is done quite late. But what then about a screening biopsy? We all know that fat biopsy and rectal biopsy are frequently done in patients with cardiac amyloidosis. But if you look here on the right, actually, fat biopsy is very poorly sensitive, especially in patients with ATTR amyloidosis. Only 15% of the patients with ATTR amyloidosis will actually have a positive biopsy. And let's say we still want to go for a cardiac biopsy because we think it's the gold standard. Once we get a tissue, what is actually the rate of getting a good result with the staining? What we found in an audit in the UK is that there is 25% of false positive results when we get when we stain the biopsy with Congo red, which is the gold standard, with a false negative rate of 10%, which is actually quite high and quite worrying. And the problem is that from across 4 years, 2015 and 2018, 3 years, this trend didn't seem to change at all. So the lesson we learned from this is that Congo red staining goes off. So if you work in a department where this is not used frequently, this needs to be refreshed. Slides need to be looked on a microscope with polarizing filters, and this seems to be a very common knowledge, but actually in the UK, 20% of UK pathology departments did not have a polarizing microscope. And 13% of the assessors failed to demonstrate amyloid, which is a quite high rate of false negative results. And also, once you diagnose amyloid, then you need to go on typing it. So to establish if it's a AL and TTR, and this can be quite complex because most lab will use histology and immunohistochemistry, but again, the false negative rate is quite high. Mass spectrometry is probably considered the gold standard, but it's relatively labor intensive and available only in few centers. So if actually getting a biopsy can be so complicated and assessing it, again, is extremely challenging. What can we do? What have we done in the last kind of 15 years to increase the number of diagnoses in these patients? Cardiac imaging has had really a prominent role in changing the way we approach diagnosis in these patients. And the two tests that really transform the pathway are cardiac MRI and bone scintigraphy. So with cardiac MRI, it's more than 15 years that we know that after the administration of the contrast, we get a very typical appearance when we use legal enhancement imaging. On the left is a normal heart, on the right, patients with amyloid. You see that what we see, there is subendocardial enhancement. You see this white line, and what we call altered kinetics. So the contrast, there is so much amyloid within the myocardium that the contrast goes out very quickly of the blood pool into the myocardium. And so you see that the blood becomes black. With the years, what we've done, we've refined the imaging technique. For the ones of you who perform cardiac MR, they know that when we have patients with diffuse disease, such as amyloidosis, we should use a specific type of reconstruction, which is called PSIR, which is much more robust when we do LG imaging. And what we learned using this more advanced type of reconstruction is that in amyloidosis, we can identify 3 different patterns. No late gad, so no significant cardiac involvement. Subendocardial late gad, so there is a line of enhancement. And then when the whole myocardium becomes white, then is defined transmural leg enhancement. And what we learn is that this imaging is highly characteristic of cardiac amyloidosis, and this has really helped to raise the suspicion when a patient goes and have a cardiac MR. The other test that has been really transforming the way we diagnose ATTR amyloidosis has been bone scintigraphy. With bone scintigraphy, the approach is extremely simple. What we do, we use a bone tracer to look for any evidence of cardiac uptake. So a normal bone scintigraphy is the one on the left. There is bone uptake, but no cardiac uptake. Then grade 1, 2, and 3 is defined as increasing the cardiac uptake and decreasing the bone uptake. So grade 1 is just mild cardiac uptake with no attenuation in the bone. 2, moderate cardiac uptake with greater than the bone, and 3, when there's a strong cardiac uptake with little or no bone signal. But then, how do we use DPD in clinical practice? This was published by Julian Gilmore in a multinational collaboration in 2016 Circulation, and I would say that this is really the paper that completely transformed our approach to ATTR amyloidosis. So if you look on the right, when you suspect ATTR amyloidosis, if you go on and have a bone scintigraphy and you find a grade 2 and 3 bone scintigraphy, but this has to be in the absence of a plasma cell dyscrasia. So normal free light chain serum, negative blood and urine electrophoresis and immunofixation, then you can confirm a diagnosis of cardiac ATTR amyloidosis without the need of any biopsy. And the only extra step that you need to do is TTR genotyping to define if it's variant ATTR or wild type. But then how do we integrate this imaging into clinical practice? So when we think about clinical practice of a cardiologist, then we have 2 common clinical scenarios. One are patients with known systemic amyloidosis, and we want to know if there is cardiac involvement. And the other far more common clinical scenario is when patients present to us with an hypertrophic phenotype, and we want to know if the hypertrophic phenotype is actually cardiac amyloidosis. But let's start with the first one, the less common one. So we can have either patients with systemic ATTR amyloidosis, like for example, patient with peripheral neuropathy, or patient with systemic AL. In patients with ATTR amyloidosis, I would say that you can go and do straight away a bone scintigraphy, which is possibly the most sensitive test to identify cardiac involvement. Although you need to be aware there are some rare mutations where the bone scintigraphy can be falsely negative. Instead, in patients with systemic AL amyloidosis, then you should do a cardiac MRI, because bone scintigraphy is only positive in less than 40% of the patients with systemic AL, with cardiac AL amyloidosis, while CMR is extremely sensitive. But what then about the far more common clinical scenarios of patients with an hypertrophic phenotype? Definitely CMR has got a prominent role because it identifies both type of cardiac involvement, but also will give you information about all the wide range of differentials in the hypertrophic phenotype. But let's have just a few clinical examples to give you an example of how we integrate this test in clinical practice. This one is a 75-year-old gentleman with shortness of breath. The echo showed a symmetric increase in LV mass, and there is no evidence of a plasma cell dyscrasia. So you can see here that DPD is grade 2. So what is the diagnosis? If you go back to the algorithm, you can follow the right path. So a grade 2 or 2 DPD scintigraphy in the absence of a plasma cell dyscrasia, you can confirm a diagnosis of cardiac ATTR amyloidosis without the need of any biopsy. So this is a very simple case. But what about the second one? 70-year-old gentleman with shortness of breath, edema. The echo again showed increase in LV mass, but this time there is a plasma cell dyscrasia. You can see here that the cardiac uptake is only grade 1 because it's very mild. And on the CMR, we had typical features of cardiac amyloidosis. So if you go back to the algorithm, grade 1, with a plasma cell dyscrasia, the algorithm simply said there is you need specialized assessment. But now we know that grade 1, in the presence of a characteristic CMR, the chance of cardiac AL is extremely high. So then in that case, you proceed with a peripheral biopsy, like for example, a fat biopsy, to confirm the presence of AL amyloid deposits. But what about this last case? 6-year-old lady with shortness of breath, echo showed increase in LV mass, and there is no evidence of plasma cell dyscrasia. So then we did a bone scintigraphy, which is completely normal, there's no uptake. And then we did a CMR, which showed instead of myocardial enhancement or transmural, patchy LGE with a predominant mid-pole distribution. So then if you go back to the algorithm on the left, gray 0 with no plasma cell dyscrasia, the chance of cardiac amyloidosis is very low, but then reviewing the CMR, we confirmed hypertrophic cardiomyopathy. So you can see then how the echo, CMR, and bone scintigraphy are extremely useful in combination to reach a diagnosis of cardiac AL, TTR, or other hypertrophic cardiomyopathy with an hypertrophic phenotype in the different clinical cases. But then this is diagnosis. Can we go a step further? And can we actually measure the amyloid within the patients with amyloidosis? So whilst LGE, so legal enhancement with CMR, is extremely useful to make a diagnosis, and bone scintigraphy, again, is extremely useful in TTR, neither of them can be used to measure the amyloid. But with a technique that has been around for the last 15 years called T1 mapping, what we can do is do a non-contrast T1 map before GAD, give gadolinium, then we repeat the post-contrast T1 map, and we get what we call extracellular volume map. So pixel by pixel quantification of the extracellular volume. And why this is relevant in amyloidosis? Because what happens is that the amyloid sits in the extracellular space. So in amyloidosis, extracellular volume is sky high compared to all other diseases with an hypertrophic phenotype. And why it's relevant in clinical practice? These are 2 patients with hATTR amyloidosis, ATTR amyloidosis, I think they were wild type. Same increase in LV mass, same degree of diastolic and systolic failure. So one might think, oh, probably they are at the same disease stage. But actually, if you look at the extracellular volume map, the difference is striking. In one, the extracellular volume is 39%, in the one at the bottom, 62%. So in spite of the same increase in LV mass and same degree of systolic and diastolic failure, the degree of amyloid within the myocardium itself is widely different. And so what we can do by using CMR, T1, ECV mapping, and LG, we can really reconstruct the natural history of amyloid deposition, and we can track progression over time. And because the amyloid, the ECV is a measure of the amyloid burden, it doesn't surprise that the worse the amyloid, the worse the prognosis. So we can measure the amyloid in the heart, but also in the liver and the spleen. So when we acquire cardiac imaging, we can also see the amyloid within the liver and the spleen. And this is an example on the left of no amyloid within the liver and the spleen. The ECV is less than 30. On the right, everybody can appreciate the difference. The liver and the spleen have become red, so there's a large amyloid load within the liver and the spleen. And this is very useful in patients with systemic AL amyloidosis because with one single scan, the CMR, you can get all the information. This is based not on extra image acquisition, but actually the liver and the spleen are almost always in the field of view when you acquire the cardiac images. And this has been validated in a study that is now published in more than 500 patients against SAP scintigraphy, which is the gold standard. So, but then why is so relevant to make a diagnosis of AL and ATTR amyloidosis? So now in the last 15 years, we've seen drastic changes in the treatment available. So first of all, when we have confirmed patients with cardiac AL amyloidosis, what we need is to stratify prognosis. And we do that with blood biomarkers. So by using NT-proBNP and troponin, we can nicely stratify the prognosis in these patients. In ATTR, there's the staging system which is most widely used is based on NT-proBNP and eGFR, and by using a cutoff of 3045, we can stratify the prognosis of the patients. But then in systemic AL amyloidosis, what do we need to do treatment-wise once we have diagnosed the patient? So It's extremely important to treat early, because the more advanced the patient is, the worse is the prognosis of the patient. And the way we treat amyloidosis of AL type is with chemotherapy. So what we do, we try to kill the abnormal cells in the bone marrow that are able to produce the protein. And by doing that, we reduce the amyloid production. And what we've seen is that rapid hematological responses improve outcomes also in patients with very advanced cardiac amyloidosis. So it's extremely important to diagnose patients with AL amyloidosis early and to start treatment early. Even a month on delay in start treatment is associated with a worse prognosis. So AL amyloidosis, from our point of view, is really a kind of an urgent treatment. We need to really start urgent treatment. But what about ATTR amyloidosis? For many years, the only treatment that we had in patients with hereditary ATTR amyloidosis with the mutation V30-MET was liver transplant. So because in these patients there was the liver which was producing the abnormal protein and then was misfolded in deposits, then what we did was do a liver transplant. But then we saw that there was accelerated cardiac amyloidosis post liver transplant in non-V30-MET. So this treatment was really just done in patients with V30-MET hereditary ATTR amyloidosis. So we didn't have much choice for the wider population of patients with ATTR amyloidosis. But this has drastically changed in the last five years. So these were the first two drugs. These are RNA inhibitor, one from Alnylam and one from Ionis Axia, that were able to demonstrate in vivo the ability to reduce the amyloid production by reducing the TTR concentration by respectively 85 and 80%. So the mode of action of this drug was basically stopping the production of amyloid by interfering with the RNA. The ability to do so was also confirmed in a phase 3 study for patisiran, the Apollo study, and there was an 87% mean reduction in the TTR concentration from baseline over 18 months. But most importantly, this was associated with improved not only reduction in the progression of the peripheral neuropathy, but also regression in some other patients. What it must be stressed is that these patients, this study had a kind of neurological endpoint. So it was a neurological study rather than a cardiomyopathic study, but actually there was a subgroup of patients. Just 1 second, I need to check why the laptop is not charging. Sorry. Okay, I seem to have an issue with battery. Just 1 second. I don't understand why it doesn't charge. Just 1 second. Okay, now it's charging. So, but whilst the study was a neurological study, a sub-analysis in the group of patients with cardiac involvement highlighted that there were differences in NT-proBNP, wall thickness and longitudinal strain, as well as 6-minute walking test in the patients with cardiac involvement. And when the recurrent hospitalization and death events by treatment arm were analyzed, again, it was a post-hoc analysis, but it was approximately a 50% reduction in the event rate, in the composite rate of all-cause mortality, hospitalization, and mortality. But what about the other drug, so inotersen by Axia and Ionis? Again, they were able to demonstrate a reduction in the TTR production. And again, in the phase 3 study with neurological endpoint, there was evidence of slowing the progression of the neuropathy. but no assessment was done in the subgroup of patients with cardiac involvement. So I've just shown you that we can reduce the supply of amyloid precursor. We can do that in AL with chemotherapy and in TTR with patisiran and inotersen. But we can also stabilize the amyloid forming protein. And the only stabilizer that is now approved for the treatment of patients with cardiac ATTR amyloidosis is tafamidis. So tafamidis is really the only drug that has ever been approved for patients with cardiac amyloidosis of ATTR type. And the approval has been subsequent to the publication of the ATTRACT study. This was a study where tafamidis was given at a dose of tafamidis 80 milligram or 20 milligram, and this was compared against placebo. And at 18 months, there was a reduction in the composite endpoint of all-cause mortality and cardiovascular-related hospitalization. But there was also evidence of a slowing in the progression of the reduction in the 6-minute walking test and in the progression of the worsening in the quality of life. And so tafamidis has really transformed kind of our approach to this patient, because this was the first drug that was approved for patients with cardiac ATTR amyloidosis. Because the other two, the inotersen and patisiran, are currently only approved in patients with a neurological phenotype, although phase 3 studies are currently going on for patients with cardiac involvement. But then we can target the production of amyloid, we can target the stabilization of the protein, but there are some drugs also that try to target the removal. This study was published in 2015 in the English Journal of Medicine, and basically this was a phase 1 study proving that anti-SAP antibodies were able to remove the amyloid from the liver, the kidney, and the spleen. Unfortunately, that phase 2 study in cardiac patients was stopped because evidence of potential side effects and no evidence of great efficacy. But other companies are trying to develop antibodies, and this would be kind of an ideal type of approach, because whilst reducing the production can slow disease progression, really to get good amyloid regression, we need to target the amyloid deposits. So this is what has been published in terms of both neurological but also cardiac studies. But there is a wide range of trials that are currently going on at the different stage of drug development, like AG10 is a stabilizer in a phase 3, and then patisiran and vutrisiran, as well as the second generation Ionis, there are phase 3 studies currently going on. So in conclusion, cardiac amyloidosis is a rapidly progressing fatal disease for which effective treatments are available. So echocardiography is useful to raise the suspicion of cardiac amyloidosis and stratify the probability, but CMR and Dpt have a crucial role in confirming the diagnosis, because what they do is they really provide information on the tissue composition. Typing is essential, so distinguish between AL and TTR is essential, since the treatment is widely different. And early diagnosis, to start early treatment, is a crucial step to improve patient prognosis. Thank you very much for the attention.
Thank you very much, Marianna, for this outstanding lecture. It's very, very comprehensive point of view. Thank you very much. So we are going to start. I don't know, Eduardo, do you want to? Eduardo is a heart failure leader here in Argentina. He's the president of the Argentine Federation of Cardiology. So, Eduardo.
Pleasure meeting you.
Nice to meet you. Thank you. Thank you for your outstanding presentation. As a clinician, I am worried about the increasing number of paper showing that there is a sub-diagnosis in different settings, in particular in heart failure with preserved ejection fraction. So I would like to know how important is, from your point of view, a systematic screening in most of them, or we only should focus on those with red flags?
I mean, this is a very interesting question, and I think it's very relevant nowadays because, as you say, there are some papers saying that a huge number of heart failure with preserved ejection fraction have ATTR amyloidosis, although I'm not entirely convinced that the number which have been published are really realistic. I think it's a bit of an overstatement, at least for some of the papers. But of course, because now we have treatment, then it's very important to know then exactly what do we do. The slight problem that we have is that while these tests are very effective, we have tested them only in patients with high probability. So where, as you say, there was a clinical suspicion driven by other red flags of the type of presentation and everything. I do not think we have strong evidence to suggest just screening, because the problem is that while the test can be extremely good in a setting with high probability of the disease, can be absolutely rubbish as a screening test. And I think we are not there yet to actually recommend the use of this test for wide screening across the population of patients. So I think it's still really is the clinician suspicion that has to drive then the further testing.
Okay, thank you. Thank you. I think it's very important to be alert about the red flags. It's better that the screening all of patients with the heart failure preserved ejection fraction.
Completely agree. Completely agree.
Thank you, Marianna, for your
Diego
okay.
Jorge.
No,
Jorge.
Jorge, go ahead.
Thank you, Marianna, for your conference. Very, very nice. I have two questions. One is if we have an echo study suggestive of amyloidosis, and MRI is always do before the nuclear study? And
no.
Okay.
I don't think so, because, for example, if you have an echo which is really suggestive, and you have done a screening from plasma cell dyscrasia and that is negative, then your suspicion is really TTR. So you should proceed with a bone scintigraphy. However, if then the bone scintigraphy is negative, but you still really suspect it, you should proceed with a CMR. First, because there are some mutations, even though rare, which are negative on bone scintigraphy. And secondly, because cardiac AL amyloidosis can be present without evidence of plasma cell dyscrasia in 2.5% of the patients. So I think if you just go with bone scintigraphy, but if still you think, even if the bone scintigraphy is negative, you still suspect something going on, just go for a CMR. Instead, if you suspect cardiac amyloidosis and you are certain of the type, then definitely CMR first.
And the second question is if the first step after the echo or MRI suggestive is the nuclear study or laboratory with light chairs for plums dyscrasia?
I think the imaging and the laboratory tests need to be done at the same time because they're both essential. In the sense, it's really the combination of the laboratory test plus CMR and DPD, which gives you the answer. So as soon as you suspect amyloidosis, the bloods, they have to be done.
Okay. Thank you.
Diego?
Marianna, amazing presentation. We have lot of questions for you. Prognosis systems are based on biomarkers and kidney function for AL and TTR amyloidosis. And imaging nicely shows the compromise of the heart, but are not included in the risk schemes to assess the prognosis in patients. How we can add imaging data that shows there is some data about prognosis into a risk model that includes biomarkers, kidney function, and imaging. There is nothing outside to show how to include all in one risk score?
Yeah, so basically, I think, as you say, then there's nothing which I mean, there are a few papers showing that LV strain by LV strain with echocardiography is an additional kind of useful prognostic marker, which is independent from the anti-BNP troponin EGFR. So definitely assessing cardiac function with strain is extremely useful, as well as assessing the amount of amyloid with extracellular volume. But the reasons why almost I focus on the blood biomarkers is because I find that sometimes doing a very expensive test such as CMR with ECV to stratify prognosis, when you can do so also with blood biomarkers, it could be a bit overdue in the sense when I see the patients, of course, I take into consideration anti-BNP troponin, echo, CMR, and everything combines together. But I would say, if you want to have the most cost-effective type of assessment, you can rely on biomarkers. But definitely papers have clearly shown that adding strain and adding ECV incrementally added to the prognosis stratification.
Marianna, you have the data, I'm sure. And if you do a multivariate analysis, and you add ECV and add biomarkers, ECV is dropped from the model. What is your data? I'm sure both are.
Yes, ECV is not dropped from the model. And this has been published for both AL and TTR. I think AL was the European Journal and TTR was JACC. So both ECV and strain do remain independent predictor of prognosis. And to be honest, it makes complete sense because, as the example I've shown you, there are plenty of patients where same increase in LV mass, same decrease of systolic function, but actually the myocardial tissue composition is very different. Because if we think about it, when we think about an 85, extremely commonly they've got hypertension as well. So some of the increase in LV mass is due also to other pathologies. And the only way to really disentangle that is to have information about what is actually the tissue composition.
Juan Bonelli.
Hi, Marianna. Congrats for your presentation. Marianna, I saw that you use a role in spleen and in the liver. No, I don't know if for identify systemic amyloidosis, and which is the cutoff that you use for identify ECV.
Yeah, so
for liver around 29%, and I don't know spleen.
So basically, for a normal liver and spleen is roughly less than 30, so similar to the heart. But to have a cutoff which have a good sensitivity and specificity, then we use 40. Because between 30 and 40, you're really in the gray zone where it could just be a bit of congestion, especially in the liver, because obviously this patient got heart failure, so liver congestion as well. But an ECV of the liver or the spleen of more than 40 has got an area under curve of 0.9 to identify moderate or severe amyloid load. So it's actually quite useful. And what we didn't realize at the beginning is that you don't need to acquire extra imaging because more than 95% of the time, so when you acquire the short axis of the T1 map for the heart, you have the liver and the spleen as well. So the only thing is really, I mean, I need to force myself to think, okay, the heart is not the only thing that counts, just zoom out, draw two regional interests in the liver and the spleen, and then you can get information about everything else. But in a sense, as a cardiologist, I'm not a radiologist, so as a cardiologist, I was so, in a way, narrow-minded to say, that's the only thing I look. And actually was my director, Philip Hawkins, who's one of the brightest minds I've met, who told me, Marianna, can you actually look at the liver and the spleen as well? And suddenly I realized, wow, these actually are red instead of blue. And so that's when we realized you can actually do an overall assessment of what's the amyloid load.
Okay, and do you use 4-chamber for identify ECV, and you use short axis too?
Yes, so what we do is we do 1 4-chamber and 3 short axis. Because what we find is that when we try to track changes over time, then you have a quite complete view of what goes on. And then you can really you have all the 4-chamber and 3 side by side, and you can see easily what goes on. And usually you identify the liver and the spleen in the short axis.
Thank you very much.
Marianna, I have a question. I would like you to know your take about what is the positivity of the bone scintigraphy and the real disease, you know? Because don't you think that we have an overestimation of the prevalence of this disease?
Yeah, I completely agree. So what happened is that, for example, in all the studies where, you know, like in aortic stenosis, they quote 15%, 18% prevalence of amyloidosis. So first of all, DPD positivity doesn't mean cardiac amyloidosis, because a bit of grade 1 in TTR just means that the patient has got some amyloid deposits, which is completely different from cardiac amyloidosis. And all these studies, what they've done, they've grouped all the positivity together and they said prevalence of cardiac amyloidosis of 18, when actually, if you look into it, some of it is grade 1. And if you, for example, assess a patient with grade 1 and no other comorbidities, from a cardiac phenotype, the heart is completely normal. So first of all, we have a problem where positivity on bone scintigraphy doesn't equal cardiac amyloidosis. And so definitely for me, there is an overstatement on this paper on the real prevalence of the clinical condition.
Thank you very much.
Difficult to say, for example, when you have a DPD grade 2 and aortic stenosis, which one is kind of the most prevalent one. But for example, grade 1, I think defining those patients as cardiac amyloidosis is definitely an overstatement.
Okay, thank you.
Carlos, ¿otra pregunta? ¿Puedo hacer? Keeping in mind...
The last one, yes, Eduardo, go ahead.
Okay, keeping in mind that an important group of patients with ATTR are elderly, do you think that the age is a limitation to start the treatment? You have a limit of age?
It's an interesting question. So, for example, the HELIOS-B, which is the second generation of the patisiran, which was the phase 3 from Alnylam, the age limit was 85 for inclusion in the study. Ionis, which is the other company in Ottersen, and then they are testing the second generation, the phase 3, the upper inclusion is 90. So
okay.
we will know very soon, but I think we are really kind of going very far on when starting treatment.
But in your practice, what do you do?
So in our practice, in the UK, tafamidis is not approved. So we don't have any drug which we can prescribe on the NHS for cardiac patients. So what we have is only patients with peripheral neuropathy. So in practice, what we try to do when we have a patient with hereditary, we really try to look for any evidence of early neuropathy so we can start the treatment and we are pretty sure the cardiac side will benefit.
Okay, thank you.
So Marianna, we know you have to leave, so we will leave you escape from this meeting. Thank you very much. It was amazing.
Thank you. It was a pleasure.
And I hope the next time we will see you in person in Argentina.
Absolutely. Thank you so much. Bye-bye.
Bye.
Yes, bye.
Thank you.
Bye.
Thank
Bye.
you.
Gracias, Diego, Eduardo y Jorge. Excelente.
Gracias, Carlos, por la invitación.
Gracias por la invitación.
Gracias, Juan.
Muchas gracias. Thank you, Marianna.
Gracias. Chao, Juan. Hasta luego.
Thank you,
Chao,
Marianna.
nos vemos.
Bye, bye.
Bye.